Good evening, ladies and gentlemen. Welcome to the first aid AMC trial class for the MCQ sample question solvation. My name is Rabia, and I'm one of the tutors associated with this course. I welcome all of you. Before we start, let's just wait a couple of more minutes so that maximum number of participants can join, and then we will start our class today. Hello, Dr. Prakash. Hello, Dr. Saroj. How are you guys?
Thanks, Cecile.
Good. Thank you. So during this recall session, what I'm going to do is give you just give you a review of what the course is about and how we help you guys get equipped with the skills to pass the exam. So the MCQ courses, it's a 5-month course. And in those 5 months, you will have 3 to 4 classes each week. The ID password of the class will be placed in the group, in the Facebook that we make for each badge beforehand, and you'll get a schedule of the whole month beforehand. Now we are the course, and I'm proud to say I've been working with this course for the last 3 years. I was also a student of First Aid AMC. I did my AMC MCQ course and the clinical course through this, and I passed my AMC exam and clinical exam in first go, and I'm currently working in an Australian health system. So I'm very proud to say that we are the course which is associated with the highest percentage of passing rate. We not only provide you the basic knowledge, we also help you guys get equipped with how to navigate the Australian healthcare system and give you information so that you are not overwhelmed when you start working in the future. So as I was saying, it's a 5 months course. You will have approximately 4 to 3 classes every week. One or two of which will be a theoretical class, which will be covered by Dr. Arshan, who is the main coordinator of this course. And then there will be simple question solvation classes, which will be taken by 2 or 3 tutors other than me. So in the sample question classes, we usually discuss the questions which are given by the candidates who are taking the exam. And we try to discuss the ways that help you guys get equipped with the skills to solve the MCQs in your exam in appropriate manner, in a timely fashion, so that you manage your time and gain maximum passing rate as well. Now, in this course, we will be going through different study material. So I have organized this presentation from the sample questions of the year 2024. The study material that we use is the John Murtagh, which is the book for your theory. It covers everything. It covers the general population. It covers gynecology and obstetrics. It covers the psychiatry, pediatrics, male population, female population, the population medicine as well. So when you're joining our course, we will provide you with a soft copy for the latest edition of the John Murtagh, because the guidelines are updated every year with the evidence-based research. So the John Murtagh is also updated every year. We'll provide you with the latest edition soft copy. And when I'm navigating through the sample questions, I usually follow the guidelines associated with the sites of the Australian health system. It's RACGP, which is the General Practitioner Guideline, SA Health, which I usually use, and it's very appropriate for obstetric and gynecological diseases. New South Wales has very good emergency guidelines. Victoria has very good pediatric guideline. Royal Children's Hospital also has evidence-based guidelines for approach towards the diseases of the pediatric age group. And RANSCOG is a guideline that has all of the PDF soft copies available on their site for psychiatric cases as well. We also use Kaplan in our course as well for some of the topics which are well written over there and makes a bit more sense. So that will be guided by Dr. Arshan, and we will help you with the guideline sites. Also, sometimes we use, if we can't find it in the guidelines, we can find them on the NCBI, or we can find it from Hello Health Service Victoria, some sites which are associated with Australian health system, which are not mentioned here, but we will always give you the link for these sites in the recall question, sample question class. Do anyone have any questions before I start the sample question solvation class for today? If you have any questions, I would recommend you please post it as a message in the chat box. Okay, so Dr. Prakash, ma'am, theory provided by course is enough, or do we need to read the books? We go through the JM in the theory class. So theory provided by the course is the full, you go through the full John Murtagh in 5 months. And it's more than enough. Once you go through John Murtagh and guidelines, then you're equipped with the knowledge. You have a very good grip on the basic concepts and the approach to managing the patient or whatever they ask in your question. And then you're equipped with that knowledge to solve the questions appropriately. All right. No worries. So the first question here I have here is from the psychiatric section. There is a 32-year-old female. So whenever I underline something, that is the key information that I want you to concentrate on. So age, sex, comorbidities, what symptoms they are coming with, vital signs, which medications they are on, and what they have asked in the last line is the key information that you need to understand about the question. So a 32-year-old female has agoraphobia. Substances to exclude before starting the treatment with SSRI is which of the following? So this patient has agoraphobia, meaning she is afraid of small spaces. And the doctor is wanting to start the patient on SSRI, which is serotonin reuptake inhibitor, antidepressants. So which of the substance of the following 4 options you want to exclude before you start a patient on an SSRI? Chocolate, caffeine, cannabis, or diazepam? Why do you want to stop caffeine in this patient when you are starting the patient on antidepressants? Can you give me every option they have given has a rationalization. So you're choosing caffeine because you think chocolate is not going to interact, cannabis is not going to interact, and diazepam is not going to interact. Is that right? What's the rationalization of you choosing caffeine? Can anyone tell me in the chat box? Why we are stopping the caffeine? Because majority of you have given the answer B. P450 system. No. Sleep disturbance. Agoraphobia patients have anxiety. They can do with sleep hygiene, sure, but that's not what they're asking in this question. What they're asking is that which of the substance you want to exclude before you start the patient on a serotonin reuptake inhibitor, right? So what they're trying to say is that which substance should not be in a patient's system before you start SSRI, so that SSRI doesn't react with it and cause serotonin syndrome. So which of the following can cause serotonin syndrome if given with the SSRI? That's what they're trying to ask. Very good, Dr. Madhupriya. So it's cannabis. Cannabis causes serotonin syndrome if given with SSRI because it increases the concentration of SSRI in the body, and that leads to serotonin syndrome. So any patient who has to be started on the SSRI, there are a couple of medications that we need to be very careful about, and we should always ask them about any substance misuse. So cannabis, and methamphetamine, ice, in other words, or some common medications should not be mixed with the cannabis, SSRI, because they can cause serotonin syndrome. So I have given a source here. Let's have a look at that. Okay. So if you look over here, risk of mixing the marijuana and antidepressant, this is the source I'm going through. It's an American article. So mixing marijuana with the antidepressants. So why it's very dangerous? Because the cannabis prevents your body from eliminating the antidepressant as rapidly as it should. As a result, cannabis/marijuana can rise the amounts of SSRI in your system and cause serotonin syndrome. And we all know that it's a life-threatening condition, as it leads to elevated serotonin levels in the body, which causes high blood pressure, tachycardia, fever, and it's a medical emergency that you have to treat in a patient. You have to warm the body, you have to control the blood pressure. If the patient is having hypotension, you need to fluid resuscitate them. And if the patient is not responding, you need to give the patient an antidote to decrease the amount of serotonin in the body. That's why SSRI, SNRI, TCAs should not be mixed with marijuana. Always ask the patient mechanism of action of cannabis. Don't know the basic pathophysiology, but if you look over here, it acts through the presynaptic cannabinoid receptors to regulate the neurotransmitter release in the brain. So if you are interacting it with an SSRI, this can cause the SSRI blockade on the receptors because it's already occupying that. In this way, the SSRI the concentration gets very high in the blood level, and it stays in the body a longer period of time, leading to serotonin syndrome to happen. Is it clear? Okay. Anybody has any question in their mind they want to ask? So always look at the last line. The last line is the most crucial information they have given you in the question, because it tells you basically about what they're trying to ask you, what information they want. So substances to exclude before starting the patient on an SSRI means that they want to exclude the substance that can lead to serotonin syndrome. All right? Okay. Next question is, which of them is used in pregnancy, which is associated with decreased risk of congenital birth defect? Number 1, iron. Number 2, vitamin D. Number C, iodine. Number D, vitamin B12 and folate. And number E, vitamin A. All right. Excellent. So we all know that not vitamin B12, but folate or folic acid is imperative to prevent what? What does it prevent? Very good. It prevents neural tube defects, especially spina bifida. So we know that whenever a patient is trying to get pregnant or has gotten pregnant and has the first urine dipstick positive, on the first visit to the doctor, we start the patient on the folic acid supplementation along with other things. So this is one of the substances that prevents the neural tube defects associated in pregnancy. Excellent. Iron can prevent anemia, but it is not associated with a congenital birth defect. Similarly, vitamin D is not associated with any congenital birth defect if there is a deficiency of it. Sure, the baby can have decreased level of vitamin D in the body leading to soft bones, but there can't be a congenital birth defect. Iodine doesn't cause congenital birth defect, but it does cause growth restriction. And vitamin A, the deficiency of it is not very life-threatening, but high levels of vitamin A is associated with baby heart defects. So vitamin A and E should be used in moderation during the pregnancy. It's not recommended to take supplementations of it unless the doctor has prescribed it to you. Folate is more important. Out of B12 and folate, folic acid is more important. Okay, so this is the NCBI evidence-based research they did about it. Okay, so they have given different substances. Maternal iron deficiency has a direct impact on the neonatal iron stores and birth weight. It can cause cognitive and behavioral problems in the childhood, but is not associated with any congenital defects. So if a patient is having low supplement or low levels of iron in the body, we always recommend them to have iron supplementation. Calcium deficiency, we all know, very, very important. It's associated with the preeclampsia and intrauterine growth restriction, and supplementation may reduce the risk of it. Magnesium can cause hematological and teratogenic damage. So if there is reduced magnesium, then just you eat the normal diet. We don't supplement it or over supplement it. Zinc deficiency, fetal growth limitation. What else? Selenium is an antioxidant. Its deficiency is associated with abortion, preeclampsia, IUGR. Vitamin B6 is associated with preeclampsia as well. Also with the neurological disease of the infants. Folic acid or folate deficiency lead to congenital malformation, which is neural tube defects. It can also lead to orofacial clefts like cleft palate and cardiac anomalies, anemia, spontaneous abortion, preeclampsia, IUGR, and placental abruption. So very, very important. Overall, not even in Australia, worldwide, it's recommended that you give a patient with 400 micrograms per day of folic acid, especially in the first 3 months. And patients who are high risk, for example, patients who have preeclampsia, patients who are diabetic, patients who had a baby which is born with the neural tube defect, or patient who has family history of neural tube defects, we recommend that 5 milligram of, not even microgram, milligram of folic acid is recommended in those patients. Similarly, vitamin D deficiency just causes soft bones, so just supplement that. It's more associated with maternal health. Vitamin E should be used carefully. Similarly, vitamin A should be used carefully because both are petotoxic. All right. Is it clear, everybody? Pre-pregnancy, if a patient is planning for pregnancy, then 400 microgram. But if it's a high-risk patient, 5 milligram per day. All right, next question. This is a bit tricky one. A patient is being investigated. His blood tests show high parathyroid hormone level and high calcium level. Rest of the labs are normal. Which one of the following is the diagnosis? Primary hyperparathyroidism, hyperthyroidism, familial hypocalciuric hypercalcemia of the malignancy. So just the parathyroid hormone is high and the calcium level is high. Let us go through this table together to understand what is the lab changes in different diseases. Okay. If you guys look over here, if your parathyroid hormones are high and it causes the calcium levels to be elevated, it can be a primary hyperparathyroidism. It can be an adenoma that is secreting excess levels of parathyroid hormone that is leading to high calcium levels. In hypercalcemia of the malignancy, because malignancy always has high calcium component, parathyroid hormone is not being is not secreted, or it's going to be a bit depressed because of the elevated calcium level in the body by a negative feedback mechanism. So hypercalcemia of the malignancy, unless it's that of the parathyroid hormone gland itself, the parathyroid hormone level will either be normal, number one, or it will be low. And they will always give you some clues in the question, like patient has weight loss, night sweat, patient has been diagnosed with some cancer, or patient they will give you some clues that there is some underlying malignancy going on, and they will give you the lab results associated with it. In renal failure, because I'll show you the pathway of the parathyroid hormone. Are you guys able to see this on the screen? So the pathway of the parathyroid hormone is that it acts on the bones, cause the osteoclast to convert into osteoblast that lies the bone and causes calcium reabsorption and increases the calcium level in the blood. Similarly, it acts on the kidneys and cause tubular calcium reabsorption. And through the kidneys, it also causes the activation of the vitamin D, which acts on the GI system and causes the intestinal calcium reabsorption. So if a patient is having renal failure, what will happen is that parathyroid hormone will not be able to act on the kidneys, that can cause the parathyroid hormones to be elevated. And as the kidneys are not being able to absorb the calcium, so calcium will be more in the urine. So the level of the calcium will be decreased in the serum. Is it clear, guys? This is also a cause of the secondary hyperparathyroidism. The third one is hypoparathyroidism, in which the level of the parathyroid hormone will be decreased, leading to decreased calcium levels in the blood. So absolutely right. Oh, where was I? Where is the question? Okay. Okay, I'll share the image. This one. And this one is the pathway of the parathyroid hormone mechanism of action. It's the similar causes of the parathyroid hormone, but what I want you to go through is this one. There is another condition which is called familial hypocalciuric hypercalcinemia. as the name indicate, it's a familial condition, meaning it passes in the family. The excretion of the calcium is low in the urine, whereas in primary hyperparathyroidism, it's high. Symptoms of hypercalcemia is more in hyperparathyroidism than in familial. Hypocalciuric hypercalcemia. And if you do a system BB scan, it's a scan which shows whether a parathyroid gland has a hot or cold nodule, right? So if it's an adenoma, it will show up as a hot nodule. So if you do a system BB scan, it usually shows as a hot nodule in the primary hyperparathyroidism if there is an adenoma, but it will be normal, or there will be no abnormal parathyroid tissue demonstrable in the familial hypocalciuric hypercalcemia. Clear, guys? All good? Any questions? Okay, that's good. Let's move on to the next one. All right. Okay, repeat this. The difference between primary hyperparathyroidism and familial hypocalciuric hypocalcemia is that familial will have a family history. They will give you, oh, the mother or the father or the paternal or maternal side, uncles or aunt somewhere has the similar condition, right? Plus the excretion of the fractional calcium through the urine will be much more in the hypoparathyroidism rather than in hypocalciuric hypercalcemia. The name indicates that hypocalciuric, meaning less amount of calcium in the urine. Symptoms of hypercalcemia will be more in primary hyperparathyroidism rather than the hypocalciuric hypercalcemia. And the scan will not show any abnormal tissue. Osteoblast osteolyase will increase the calcium reabsorption, leading to increased serum calcium. Okay. Why in asymptomatic and familial despite of hypercalcemia? I'm sorry, I have no idea why that is that. I don't know the pathophysiology behind that. Well, let me have a look. Okay, so if you have a familial hypercalciuric hypercalcemia and it's exhibited, there is no rationalization behind it, but if it starts exhibiting the signs of failure to thrive, dehydration, or demineralization of the skeleton or skeletal deformities in the first week of the life, then there are different forms of it. Then this is the severe form of it. There is also a milder form in which the patient lives a normal life. That's the answer to your question, Dr. Prakash. All right. Next question. So different forms of it. If you have a mild form, you won't have symptoms unless there is a trigger. But if you have a severe form, you will have the symptoms from the first week of life. 80-year-old male patient is coming to you with constipation, but there is no vomiting. Abdominal X-ray, if you can see, there is a dilated, transverse, and ascending colon, but there is no air fluid. There is no air in the rectum. So there is a cutoff sign over here. What is the most likely diagnosis? Is it a colon cancer? Is it a diverticulitis? Is it adhesion to the colon? Or is it mechanical large bowel obstruction? All right, so majority has given answer D, some has given answer as C, a few as B. All right, let's discuss it one by one by putting logic behind it. It's an 80-year-old male patient who is coming to the hospital with long-standing constipation, no vomiting. So if there is no vomiting, meaning it's a mild or a starting of the intestinal obstruction. So they did first thing that you need to do in a patient who is presenting you with symptoms of abdominal obstruction is that you do an erect abdominal X-ray. So they did that in the patient, and you can see that the ascending colon and the transverse colon is very much dilated, and there's a cutoff sign, means that we can't see the air beyond this point. So it can be cancer, it can be adhesion. We don't know what it is because they haven't given us any clinical signs of cancer. They haven't given us history, so we can exclude out cancer from here. They haven't given us history of previous abdominal surgery, so we can exclude the adhesions. Why it's not diverticulitis? You can't diagnose diverticulitis in a patient on an X-ray. You can't diagnose. You need CT scan to diagnose diverticulosis, and patients should have some systemic sign and symptoms for diverticulitis, right? So fever can be there, and diverticulitis, sure, does happen in the patients with long-standing constipation, but there are physical signs as well. They will have localized abdominal pain in diverticulitis. Like most of the time, it's a sigmoid colon which is involved in the diverticulitis. So you will have left lower quadrant pain. And patients with diverticulitis will have vomiting as well. And diverticulitis, as the name indicates, it's an inflammation of the colon. So if you palpate the abdomen, there will be tenderness and there will be rebound tenderness, but localized. It will not be a generalized one. Mass, you can't feel mass, but most patients will have some constipation as well. Always there will be history of constipation. So that's why it's not diverticulitis. So the best one is it's the mechanical large bowel obstruction. We can see that there is something obstructing the passage of the gas from the descending colon onwards. So we know it's a mechanical, something mechanical is obstructing that area. So it can be a mass, it can be adhesion. So it's a broader term we will use here, that it's a mechanical large bowel obstruction. Is it clear, guys? So in this patient, constipation, fecal impaction can also cause mechanical large bowel obstruction. If the patient has signs and symptoms of colon cancer, it can also cause that. If the patient has previous surgery, then adhesions can also cause that. There's another condition called volvulus that can also lead to mechanical large bowel obstruction. So the culprit for everything, including the large colon, is a long-standing constipation or cancer or surgery. So these three things, they should give you some clues in the question about it. Is it clear, guys? So you can study the large bowel. Why not adhesion? Because they haven't given us any clue about why the adhesion could be there. Adhesions don't occur spontaneously. They need to occur because of some interruption of the abdomen. So post-operatively or surgery has been done. Something like that will always be there. So you guys can study New South Wales emergency guideline. Very, very well written. Has all the information that you need for the exam. So it has no air in the rectum, means the gas is not passing through. There is no air in the rectum. There is something that is cutting off the passage of the gas from that point onwards. So you can read small bowel obstruction, toxic megacolon, large bowel obstruction, and pseudo obstruction from here. So we'll go towards the large bowel obstruction. Acute colonic distension can occur because of the following causes. It can be a mechanical one. It can be because of some inflammatory disease like inflammatory bowel disease or a Clostridium difficile infection leading to toxic megacolon. Or it can be acute colonic pseudo-obstruction, which is present in elderly patients who are on Parkinson's medication or anticholinergic medications, or patients who had post-operatively some electrolyte derangement, or a patient who just has gastroenteritis can also have pseudo-obstruction afterwards if they are having electrolyte abnormalities. So patient will present with abdominal pain, bloating, change in bowel habits, tenesmus, rectal bleeding. So if you look over here, these are the signs and symptoms of mostly cancer. So change in bowel habit, tenesmus meaning incomplete emptying of the rectum, rectal bleeding, recent weight loss, these are signs and symptoms of cancer. So if they haven't given you any clue like this in the question, don't go for cancer option. Signs will be abdominal distension will be there, tympanic abdomen, tenderness, rigidity, palpable rectal mass, or empty rectum. Risk factors, malignancy, highest risk factor, previous surgery leading to adhesions, volvulus, very common in elderly patients who are bedbound or institutionalized, meaning they live in nursing home care. Rare causes is hernia, foreign body, endometriosis. So what do is that we also exclude the life-threatening conditions like perforated viscous, pancreatitis, and AAA, which is abdominal aortic aneurysm. So how do you exclude that? You do a CT scan, and to exclude pancreatitis, we do a blood test called lipase. If the patient is not stable, we will resuscitate the patient. But if the patient is stable, then you do the complete blood test like full blood count, urea electrolytes, creatinine, liver function test, lipase, blood sugar levels, ECG for abdominal aortic aneurysm, chest X-ray. Not always, we do a erect abdominal X-ray. If it's a female, always do beta HCG because we want to rule out ectopic pregnancy as a cause of the abdominal pain. CT scan, very important. It's very specific and sensitive for colonic obstruction. So supportive care is that you make patient nil by mouth, start IV fluids, monitor the fluid balance, give analgesia, put an NG tube in to decompress the GI system. And if there is an obstruction that requires surgery, we'll go towards the surgery. Clear, guys? Any questions? Next question is, this is a tricky question, and I think this will be something you might have read for the first time as well. A 50-year-old man had a CT scan that showed that 1 centimeter growth is present at the left lower pole of the left kidney. The growth has hairline thin walls and no calcification or solid component. No history of the stent or anything else. Which one of the following is the next best option? Option A, nephrectomy. Option B, partial nephrectomy. Option C, excision. Option D, fine needle aspiration and cytology. Or option E, no further imaging is required. So we are all going towards the answer of either surgery, excision, or fine needle aspiration and cytology. Let me show you guys something that can help you to solve the question. So let's go through this first. It's a RACGP article for incidentally detected renal masses. Okay. If you have found an incidental renal mass on a CT scan, Then we start with, if you have done a CT scan, then we do what we call as Bosniak classification, which is a categorization of the renal masses. So if you look at that, and it's based on the CT scan findings. If you look over there, Bosniak 1 says that if it's a growth with the hairline thin wall that does not have any septa, calcification, or solid components, it's a simple renal cyst and malignancy percentage is 0. So it does not require any fine needle aspiration or cytology. It does not require any excision unless it's causing pressure symptoms. What the Bosniak classification 2 says that if it's a growth that contain a few hairline thin septa in which perceived enhancement may be present, there might be slightly thickened calcification in the wall or septa, or the lesion is less than 3 centimeter, but are well marginated, then this does not require any further imaging it does not require any further evaluation by fine needle aspiration and cytology or biopsy, because the malignancy rate is less, plus minus 1%, which is very, very low. But if it's a lesion that has multiple hairline thin septa, has increased enhancement, increased calcification, is not well marginated, it's nodular, it's thickened, then this requires, and it's more than 3 centimeter, then this requires follow-up with the fine needle aspiration and cytology or biopsy and referral to the urologist. Similarly, if it's 3 and 4, that it's an indeterminate mass, you can't tell, but you do see there is irregular septal walls thickened with lots of calcification. There can be some air fluid levels. There can be some multiloculation. Then you need to rule out cancer because 35% is associated with that. Similarly, anything that is not 1, 2, 3, 2F and 3, it's categorized as 4, and these are always carcinomas and require surgical removal. Is it clear, guys? Now look at this one. Look at this flow chart now. So renal mass, if it's clinically suspected or if it's an incidental discovery on ultrasound or a CT scan. If it's an incidental discovery on an ultrasound, what you need to do is a CT scan. If it's a simple cyst, like we have discussed with the Bosniak score of 1 or 2, no further follow-up is required unless patient is symptomatic. Similarly, if it's Bosniak 2F, then follow-up imaging is required. Plus, if on any of the follow-up imaging, if the cyst is changing size, shape, or enhancement, you need to do fine needle aspiration and cytology, or you need to do a biopsy of that. Bosniak 3 and 4 require surgery with active surveillance. If on the CT scan, you have found a solid mass or a complex cyst, then you need to check the size. If it is more than 4 centimeter, solid indeterminate, then you need to do fine needle aspiration and cytology. If it's solid, then you need to do fine needle aspiration and cytology, plus you need to refer the patient to the renal cancer clinic or pathway. Now tell me what is the answer here. Very good. So it's a less than 4 centimeter, thin hairline, no calcification or solid component. So the best option is no further imaging is required in this patient. It's a simple renal cyst. Is it clear, everyone? Okay, that's good. All righty. Next question. This is a very easy question. Patient has sleep problem. Also complains of loss of interest. Has a good relationship with his girlfriend for 18 months. Is also very sad. What would you do for initial management? Option A, mirtazapine. Option B, cognitive behavioral therapy. Option C, electroconvulsive therapy. So whenever a patient is, just remember this rule of thumb, guys. Whenever a patient is coming to you with any psychiatric illness or disturbance, always start with lifestyle modifications. Then ask the patient whether he wants to have a counselor for cognitive behavioral therapy. If both of them, lifestyle modification and cognitive behavioral therapy, or any behavioral therapy that you have recommended the patient is failing, then you can refer the patient to the psychiatrist, or you can start the patient on the pharmacological management. So this patient is a bit disturbed. He's having sleep problems, loss of interest. He has a good relationship, but is also sad. So he is developing signs of depression, early signs of depression. So the initial management will be to do the cognitive behavioral therapy along with the lifestyle modification. If you look at this one, let me just open this up like this. Are you guys able to see this? Okay. So this is from the RANSCOG guideline. Okay. So Royal College of Australia and New Zealand Psychiatry. Zoom in. Okay, let's see if I can zoom in. Give me a minute, my dear. I'm not very good with computer, so I'll just zoom in like this, and we'll just scoop it up and down. Oops, sorry. Sorry about that. Okay, management of the major depressive disorder. So for the diagnosis of the major depressive disorder, patient has to fulfill the criteria, DSM-5 criteria for depression. So there can be mood changes, there can be sleep changes, loss of interest, guilt, appetite, concentration problems, psychomotor changes like hallucination in severe form, and also suicidal ideation. If the patient has 5 of the 9 symptoms persisting for more than 2 weeks, then we diagnose the man with the major depressive disorder. So the goal is that you want to completely get rid of the psychiatric symptoms in a patient of depression and develop resilience. I think it's 2 weeks, Dr. Imran. So the first step, or the step 0, is that we will do lifestyle modification. We can seize any agent that can potentially cause aggravation of the symptoms. Number 1, you can, if the patient is having sleep problems, you can institute sleep hygiene, appropriate lifestyle changes like smoking cessation or cut down on it, regular exercise, healthy diet. And if there is substance misuse, then you can also address that. Okay, if step 0 is not working, then you refer the patient to the psychological therapy. It can be cognitive behavioral therapy. It's individual based. So cognitive behavioral therapy, interpersonal therapy, acceptance and commitment therapy, mindfulness based cognitive therapy. And if cognitive behavioral therapy is not working, then you combine the cognitive behavioral therapy with the pharmacological therapy, for which the first line is SSRIs, SNRIs, NDRIs. These are all antidepressants, or melatonin agonists and serotonin modulators. Second line are the TCAs and MAO inhibitors. If even the pharmacological therapy for at least 6 to 8 weeks, patient should be on them consistently. because it requires a certain time period for the level of the antidepressants to build up in the blood and actually work. So you start with the lowest dose and gradually increase them, monitoring the patient for the signs of the serotonin syndrome. If the patient on maximum dose of the antidepressant is not having any benefit from it for 6 to 8 weeks, or if the patient has suicide ideation or has attempted suicide or is having resistant major depressive disorder, then we can think about combining the antidepressant with antipsychotic medication, or you can refer the patient for consideration of the electroconvulsive therapy. This is how we electroconvulsive therapy, ECT. So that's how you treat a major depressive disorder. Is it clear, guys? Okay. All right. $12 months for new. For new what? Sorry, Dr. Khan, I don't understand your question. All right. Let's go towards the next one. 12 months for new depression. Okay. Next question is, a woman has red itchy vagina associated with thick white discharge. Very easy question, to be honest. She's on OCP. What to advise? Stop the OCP, get metronidazole, cranberry juice, or give antifungal treatment. So we all know that a very red erythematous, itchy genitals associated with thick white discharge. Always think about candidiasis. So start the patient on the antifungal treatment while you take the swab for it and wait for the results to come back. We won't stop OCPs because OCPs and candidiasis are not, there is no association. There was a vast study done on this topic to see if the OCP is associated with increased risk of causing candidiasis. There was 1,500 patients which were followed over a period of 3 years, but there was no association found in that. You can also see the article on the NCBI for that. Okay, so for the STI guidelines, sexually transmitted infection, always go to STI Guidelines Australia. It has everything you want for your exam. Every sexually transmitted infection is written over here. So this is a Australia-wide followed guideline for the general physicians or for the general practitioners. So if you look over here, syndromes, you will find different syndromes. In STIs, you will find different STIs. Everything is on population, different population, and what's the recommendation for them? Everything is here. So candidiasis can be, it's most of the time a normal flora, but it can be sexually transmitted, but it's not considered a STI. It can rise spontaneously because of the disturbance of the vaginal flora, like a patient is having antibiotic therapies or on hormone replacement therapy, increased estrogen levels like pregnancy or postmenopausal estrogen therapy, not OCP. Dr. Faria, it's stiguidelines.org.au. Or you can just type STI Guidelines Australia in the Google search bar and this will come up. So cause, we know that it's the Candida albicans. Male and female both can have them. So in females, there will be a thick, wide, clumping vaginal discharge. It is associated with itch, burning, soreness of the genitalia, superficial dyspareunia because of the itching and burning, external dysuria because of the same itching that can cause fissures, excoriation, erythema, fissures, and swelling. Recurrent is important because it can happen. And when it is happen recurrent, then you need to check whether patient has any immunocompromised state, like rule out diabetes, rule out HIV, or rule out if patient is on the immunosuppressant therapies. So recurrent is if 4 or more episodes are happening in 1 year. So you need to rule out whether patient has diabetes, HIV, or other immunosuppression. Diagnosis, we do a high vaginal swab and send it for microscopy and culture. Management is that if it's uncomplicated, we just give azole cream, like clotrimazole vaginal cream, or you can just give 5 milligram of clotrimazole vaginal pessary. If a patient can't tolerate azoles for some reason, you can give fluconazole 150 milligram oral stat. That's it. But if it's a recurrent one, then you need to treat with fluconazole. This is very important for your exam, guys. So recurrent therapy is you give fluconazole 150 milligram, 3 doses, 3 days apart, followed by the maintenance dose of fluconazole, which is 150 milligram oral weekly for 6 months. Or alternatively, you can give azole cream for 10 to 14 days, then a vaginal pessary weekly after the induction. Candida glabrata can be treated with boric acid vaginal pessary, or you can insert nystatin as well. Excuse me. What we need to avoid is local irritants, latex barrier contraception like condoms, or in a male patient, postcoital penile hypersensitivity can happen. So you can treat the partner with hydrocortisone 1% cream for symptomatic relief. In pregnancy, we can't give azoles because they are fluconazole because they are contraindicated. So they will need clotrimazole treatment for a minimum of 7 days. No need for contact tracing. You don't need to follow up for this patient as well. All right. Is it clear, guys? Okay. Any questions, anyone? So if you want to study treatment for pregnant women is the clotrimazole topical cream, 7 days. So if you want to study STIs, go through this one. This has everything. You'll need whatever you want. It's written in there. Okay. All right. Next question, and then we'll take a 10 minutes break. 4-year-old child was brought to hospital by parents having nausea, vomiting, fever, rash on the trunk. Next investigation: blood culture, lumbar puncture, urine MCS, CT scan of the brain, or CTK. I think they've written next. Excellent. What are we suspecting in this patient? No, not of typhoid. 4-year-old child, nausea, vomiting, fever, rash on the, always suspect meningitis associated meningococcemia. So fever with rash on the body, non-blanchable, always suspect meningococcemia. So we will always start with the blood culture. Always start the investigation with the blood cultures. Lumbar puncture can be done later on, but always start the patient after resuscitation with the blood culture before you give antibiotics. So before you start the patient on empirical antibiotics, always do a enteric fever will also have diarrhea. There is no diarrhea. And the rash in the enteric fever, the rosewood rash, it appears on 4th day. It's not on the 1st day. So if it's a fever with rash on the trunk, always suspect meningitis first, not enteric fever, unless you have gastroenteritis symptoms like diarrhea. Okay. All right. Let me just open up RCH. Look at this one, guys. Symptoms can be non-specific, so early diagnostic consideration when an investigation and empiric treatment is required. So patient can have fever, irritability, lethargy, poor feeding, hypotonia, vomiting, and diarrhea as well. From temperature instability, very high grade fever and then very low. If the patient has, if a infant will not be able to tell you that, but child will tell you about headache, photophobia, nausea, and the parents are saying that patient has altered level of consciousness, always think about meningitis. So you will do a full examination. Most of the time, if the patient is less than 18 months old, you will find the anterior or posterior fontanelle to be full or bulging, high-pitched cry, fever or hypothermia, apnea, neck stiffness may be absent in the infants. Focal neurological signs can be there, purpuric rash, very important, or Kernig or Brudinsky sign, very, very important. Management, lumbar puncture is not the first thing that you do. What you do is this one: full blood count, glucose, serum sodium, and blood cultures. That's the first thing that you do. Lumbar puncture is the second diagnostic test that you do. Once you have started the patient on antibiotics, you can do the lumbar puncture. We don't need to do a CT scan because most of the time meningitis is diagnosed with blood cultures. And if we want to do a lumbar puncture, a normal head CT does not exclude the raised ICP and should not influence the decision to perform an LP. So blood cultures is the first, LP is the second. It's a must do test. Treatment, what you do is antibiotic must not be delayed for more than 30 minutes after the decision to treat is made. So once you have done the initial full blood count, Chem 20, CRP, blood cultures, start the patient on IV fluids if the patient requires it, and start the patient on enteric antibiotics, which is ceftriaxone. So less than 2 months, we start the patient on benzyl penicillin, but more than 2 months, ceftriaxone, and if MRSA, then vancomycin. And we give the patient dexamethasone as well for 4 days. So again, look at this one. Now you will be, without excluding high ICP, can we do? Yes, you can do. Don't wait for CT scan. You can do because a normal head CT scan will also have raised ICP. So what they recommend is that don't wait for a CT scan. As soon as you start the patient on antibiotics, do the LP as well. Is it clear, guys? Which test is confirmatory? Both of them. Initial is blood culture, lumbar puncture is confirmatory. Fundoscopy to rule out raised ICT, it's a very good idea, Dr. Farah. It's non-invasive and it's associated with less radiation as well. You can do fundoscopy, but if it's an infant, it's very difficult to do fundoscopy in them because they keep moving the head. It's very difficult for a child to sit down a child and do a fundoscopy. So that's why don't wait for anything else. Do the lumbar puncture after the blood cultures. So you need to do a full septic screen in a patient who comes with a high suspicion of meningitis, like full blood count, blood cultures, CRP, respiratory, virus, and bacterial panel, coagulation studies for the rash, because you want to rule out ITP as well. And ITP can present with associated infections. Lumbar puncture, and the lumbar puncture can have PCR of the for the meningococcal organisms. No, steroids is not given to all patients. It's given to the patients who are more than 2 months of age. Your LP, if you're having signs of raised intracranial pressure, like patient is having high blood pressure with the low with bradycardia, patient is having GCS of 3, then you start the patient on the treatment for ICP lowering drugs and then can do LP. But it's a must to do LP. Otherwise, you will not be able to direct your antibiotic treatment. There, guys. Okay. Let's take 10 minutes break and then we'll come back and finish this class. 10 minutes break, please. Welcome back, everyone. Let's start again. Are you guys able to see the screen? Okay, thank you. So the question is, a patient has diabetes, also coronary artery disease. The patient is also having heart failure. He is currently on 1 gram of metformin, and the HbA1c is 7.8%. Patient is also on beta blocker, spironolactone, and ACE inhibitor. What to change in the medications? Increase the metformin, add SGLT2, or add insulin? Alrighty, so everyone has answered B. Okay. Why we are adding SGLT2? Can anyone give me an explanation? Answer is absolutely right. It will have dual effects. So SGLT2 was initially discovered as a oral anti-hyperglycemic agent, but it was found through studies over the last 10 years that it also helps in the remodeling of the heart when it had been damaged from the heart failure. So whenever a patient is diagnosed with heart failure, whether they have diabetes or not, we always start the patient on 4 pillars of the heart failure medication. Number 1 is the beta blocker once the ejection fraction is stable, or if the patient is hemodynamically stable. The other one is ACE inhibitor to control the high blood pressure. Number 3 is the mineralocorticoid antagonist, which is spironolactone. And the third one is SGLT2, which is dapagliflozin. It has effect on the remodeling of the heart, strengthens the heart, and helps the heart to get over the heart failure. I'm currently working in cardiology, and I have seen a number of patients who are young, had a heart attack, had heart failure as a consequence of that, who started on the 4 pillars for the heart failure and recovered their left ventricle ejection fraction to the normal extent. So it's kind of miracle drugs they have. So the rationalization is that it was initially discovered as a diabetic medication, but later on it was found to have beneficial effects in the remodeling of the heart after a patient had a heart failure. If you look over here, this is the American College of Cardiology, which is almost the European College of Cardiology, and the American College of Cardiology is the one thing that Australian health system follows for the guidelines. So mechanisms linking diabetes to cardiovascular disease. So we know it causes micro and macrovascular problems in the patient combined with the hypercholesteremia. So what we do for the patients with diabetes associated with coronary artery disease is that we start them on antithrombotic therapy, which is either aspirin plus clopidogrel for the first 12 months or aspirin for lifelong. We control the blood pressure because it's increased risk of micro and macrovascular complications, and it causes end organ damage. The blood pressure controlling medications, the first line are the ACE inhibitors and ARBs. Second line is the calcium channel blockers and beta blockers. Dyslipidemia, we start the patient on statins, and if maximum dose of statin is not controlling the LDL level less than 1.8, then we add ezetimibe as well. Glucose control. So for glucose control, metformin is the first drug that we use, but the evidence for the long-term cardiovascular benefit with the, sorry. So sorry, I thought you guys are seeing this. So this is the American College of Cardiology. I do apologize. I thought I have shared the screen with you. So 2 guidelines are followed. Just write American College of Cardiology or European Society of Cardiology, management of stable coronary artery disease, heart failure, and diabetic patient, and this will come up. So as I was saying, for the glucose control, metformin is the first line, but the long-term effects of the metformin in association with the cardiovascular disease, especially, it's limited. But what we have found that is SGLT2 inhibitors and GLP-1 agonists are having cardiovascular benefit because they not only cause the reversal of the heart failure, but they have decreased the morbidity and mortality associated with the coronary artery disease and heart failure. So very, very important. At least by 32%, that's a major effect in the mortality and morbidity of a patient. It's a major contribution by a drug. So it not only remodels the heart, but it prevents you to die early as well in a patient, especially who is having heart failure with HFrEF with less than 40% ejection fraction. Is it clear, everyone? Okay. Next question. A 55-year-old man who has been on warfarin for atrial fibrillation for the past 3 months. Now he presented in an emergency with incarcerated inguinal hernia and was booked for emergency surgery. Warfarin was stopped and fresh frozen plasma was given. Which one of the following is the time that you restart the warfarin therapy? A, 12 hours post-op, B, 24 hours post-op, C, immediately after recovery from the anesthesia, or D, 5 days post-op, E, when the INR is less than 1.8. So the maximum time period for starting warfarin is 24 hours post-op when the INR is not less than 1.8. When the INR is in range. So for the first 12 hours, we just give patient on therapeutic, Clexane or low molecular weight heparin. And then we introduce warfarin in the first 12 to 24 hours, but maximum 24 hours period. And once the INR is established, we stop the Clexane and continue the warfarin with continue monitoring of the INR. This is the basic thing that we usually do. So the answer is the 24 hours post-op, not the first 12 hours. Okay, clear, guys? So very easy. But you guys can study about warfarin management in hospital, in community through this guideline. Let me just show you that. It's a Queensland Health. Very, very beneficial for your exam. You can use during operation, we have reversed the effect of the anticoagulant. So if required, if the patient has high risk of thromboembolism, then we do use it. Otherwise, we usually don't. Post-operatively, we use low molecular weight heparin in the first 12 hours and then introduce the warfarin. So this is the one that I'm talking about. guideline for warfarin management in the community. It's the same one that we do in the hospital as well. So please, if you have questions, go through this one. There is another, this one, hospitalized adult patients. So this one as well. So everything you need to know about anticoagulation, whatever type of anticoagulation. Sorry, give me some time. Let's just go through that project. Anything you want to remember, just follow these. Have a read. www.Queensland, just write in the Google, warfarin guideline, Queensland Health. I'll write here, warfarin guidelines, Queensland Health. It will come up with two, community and hospital. Go through both of them. Okay, guys? Fine. It's a very long book. It's a complete book. So go through it one by one. All right. Before the surgery, if it's an emergency surgery, then patient ask the patient when the last dose of warfarin was taken and stop that from onwards, and reverse the effect with vitamin K. That's the first thing. Number two is you reverse the effect with fresh frozen plasma or prothrombinax. So all of these things help. Okay. So the next question is, a patient comes with right eyelid fossa pain. Ultrasound done and stone of 4 millimeter was seen at the uretropelvic junction. What to do? Percutaneous nephrolithotomy, extracorporeal shockwave lithotripsy, or wait for the spontaneous passage. For elective Dr. Faria, we stop the warfarin 5 days before the surgery and measure the INR and see whether the patient requires bridging therapy or not. For the patients who are very high risk for thromboembolism, we usually bridge the therapy with the low molecular weight heparin or unfractioned heparin. Clear? Okay, so some of you are answering B, very few are answering A, and majority is answering C. Always remember, guys, whatever the size of the stone, if wherever the stone is, if it is less than 7 millimeter, it will spontaneously pass through the tract. So if it's 4 millimeter, it will pass. Unless it's in the area where there is stricture or something else in its way to pass spontaneously, we always wait for these stones to pass. We don't do anything else. Look at this diagram. So if you have a renal calculi, medical conservation is done if the size is less than 0.5 centimeter or 5 millimeter. If there is no hydronephrosis, no distal obstruction, no infection, then we will just wait for it to spontaneously pass. If it's a calculi in the kidney, we do extracorporeal shockwave lithotripsy if it's less than 2 centimeter. If it is present near the pelvic junction or calceal junction, there is no obstruction, no infection. We do percutaneous nephrolithotomy when the size is more than 2 centimeter in the renal area or the kidney. It's a cystine zone, or the ESWL has failed, or it's causing hydronephrosis, urinary obstruction. Open surgery is done when all else fails. Ureteric stone, again, if it is less than 0.5 centimeter, we'll wait for it to pass. If it's more than 0.5 centimeter, less than 1 centimeter, shockwave lithotripsy. Of if it is more than 1 centimeter, you need to do surgery. Urinary bladder, we do lithopexy when it is less than 2 centimeter, or open surgery if it's more than 2 centimeters. So size is very important for the renal calculi or urinary system stones. Clear, guys? All right. Next question. A child is coming to you with the swelling of the scrotum. It's not painful. If it's in ureter, transurethral removal. If it's in ureter less than 7 millimeter, it will just, or 7 millimeter, it will just pass. Okay. Child is coming to you with swelling of the scrotum. It's not painful. And scrotum can't be felt separately. I think they meant testes can't be felt separately. Scrotum is the whole thing. The swelling is going towards the penis and perineal area. What will be the diagnosis? Scrotal edema, epididymitis, testicular torsion. Very good. So this is idiopathic scrotal edema. In epididymitis, number one, it never happens in a child. It happens in young teen boys or young adults. Epididymitis, you can feel the epididymal cord separately, or it's very thickened. Patient will have fever as well, symptoms of urinary tract infection. In young adults, you need to screen the patient for the STIs as well, because it's one of the most common causes of it. Testicular torsion can happen in the young children, can happen in the young teenage boys as well. It's the testes twist around itself, causing cut off of the blood supply, leading to ischemic pain. It's very, very painful. You need to treat the patient in the first 6 hours since the presentation in the hospital, because it can cause gangrene or the death of the testes. So if there is a high suspicion, don't wait for any imaging. Just take the patient in theater and untwist the testes. One of the signs that we look for is the cremasteric reflexes absent. Also, the testes are usually in the vertical position, but they are lying in the horizontal position. Or they change the color as well if it's more than 6 hours. So let's have a look over here. This is idiopathic scrotal edema. Okay, so we look over here. Let's change the screen. Scrotal pain or swelling. This is Perth Children's Hospital guideline. So what they say is that any child with acute scrotal swelling or pain requires urgent assessment to identify or exclude two emergencies. Number one is the testicular torsion. Number two is the incarcerated involuntary death. So any imaging is not reliable to exclude or confirm testicular torsion, and it delays the definitive treatment. So we usually don't do anything. So we know acute causes are testicular torsion. So patient will have severe sudden onset of pain and swelling. They may refer to abdomen, will have nausea, vomiting, swollen discolored testes, extremely tender, high riding and horizontal lie, absent cremasteric reflex. Torsion of the hydatid of Morgagni is also there. Appendicular torsion, not emergency. It's also an emergency. Torsion of the hydatid of Morgagni. It's difficult to distinguish, but you can do a transillumination test, which we usually don't do. We just take the patient to the theater. Epididymoarthritis, very uncommon in the young boys, common in the pubertal boys. Low-grade fever, dysuria, vomiting, very tender, swollen, red-colored testes. You can feel the thickened epididymal cord. Usually have pyuria. The other emergency that we are very concerned about is the incarcerated inguinal hernia. So inguinal hernia is a testicular swelling extending the whole length of the scrotum. We can't find the upper limit of it. It's usually a indirect inguinal hernia, and patient presents with signs of bowel obstruction like pain, abdominal distension, vomiting. So you need to do X-ray and take the patient to the theater. Trauma can be there. Hemlock, Shumlin, purpura can also cause testicular swelling. Painless scrotal swelling are hydrocele and idiopathic scrotal edema. So hydroceles are usually present in young infants, and it can eliminate if you do a transillumination test. Simple hydroceles can be observed for 2 years, but if it does persist beyond 2 years, because most of the time it gets reabsorbed. If it does persist, then you can refer the patient to the pediatric surgeon for it to be aspirated. Idiopathic scrotal edema can be acutely present. There is obvious edema, purplish discoloration of the scrotal skin. Bilateral edema, you're not able to palpate the testes, but they are not enlarged, nor they are tender. You can't, most of the time, if it's very extensive, you can't palpate the testes, but it's non-tender. There's no pain. Clear, guys? Any questions? Appendicular torsion is an emergency, doctor. It's an abdominal emergency. It will not be extending towards the genital region. All right. Next question. Any question, guys, from the testicular swellings? Anything in your mind? Okay. All right. Next one is to differentiate hydrocele and edema. Do a transillumination test. Hydrocele will light up. Edema won't. And hydrocele is not bilateral, it's unilateral. And you can feel it. You can't feel the testes as well in hydrocele. It's unilateral, not bilateral, and transillumination test is positive. 68-year-old man developed right-sided apraxia, also has confusion. He cannot write, add, or subtract. Where would be the lesion be? Right parietal glioblastoma, left parietal glioblastoma, right temporal or left temporal region? All right, so majority of you are answering as B. Very good. Right-sided, so the lesion will be on the left side. We know that. And the patient has problems in, number one, he's confused, so cognition is there. Apraxia is there. And the ability, the learning ability, like writing, adding, or subtracting is impaired. So this is a parietal lesion. Let's have a look at our brain for a minute. Okay, so the frontal lobe is associated with the personality, intelligence, and judgment. So if a patient will have a frontal lobe lesion, they will have poor social skills, abnormal behavior, and they will have problems in the limbs, upper limb, lower limb, They will have problems with the memory. This is the thing which is controlled by the frontal lobe. Parietal lobe, language and reading, coordination, sensation, cognition, and reasoning. These are the things which are present and controlled by the parietal lobe. In temporal lobe, most of the sensations will be present, like vision, hearing will be present, speech, behavior is present, memory and emotions are controlled over here. Occipital lobe, we all know, is associated with vision. Cerebellum is associated with balance and coordination and fine muscle movement, whereas gross muscle movement is by frontal lobe. So always remember, behavior, personality, decision-making, memory, frontal lobe. Parietal lobe, language, reading, cognition and coordination, both of them. Temporal lobe, sensations, all of it. Speech, behavior, emotions, memory, vision and hearing. Occipital, vision. Cerebellum, balance and coordination, and brainstem is associated with the vital signs like blood pressure, breathing, heartbeat, swallowing. So our lesion is in the parietal lobe. Clear, guys? Any questions? No. Okay. Next one is, this is a quite easy one. A man is having recurrent pilonidal abscess. So that's an abscess, that image. Okay, Dr. Gayatri, just give me a minute. Have a look again. Where is it? All right, there you go. Let me just remove that red line for you. Oh, oops. Oopsies. Okay, here you go. Done? Just let me know when you're done. Okay, all righty. So a man is presenting with recurrent pilonidal abscesses. What advice you need to give? So pilonidal abscess is an abscess just above the natal cleft region. It's associated with the pilonidal sinuses. And if it's happening recurrently, we need to tell the patient that they need to shave often, because pilonidal sinus is caused by the hair follicles, impaction of the hair within the sinuses, right? Within the hair follicle, right? So we need to ask them to shave, clean the area, remove the hair. Because if there is no hair, there will be no impaction of the hairs in that area, leading to formation of sinus, leading to formation of the pilonidal abscesses. So the basic thing we can tell them, maintaining hygiene is important, but that is just not enough. If you're maintaining the hygiene, but not shaving the hair, you can still develop the pilonidal abscess, because the hair can get impacted again in the sinus or the hair follicles, leading to formation of other sinuses, leading to again formation of the pilonidal abscess. So shaving is the critical thing. You need to remove the hair, which is the culprit of the disease. So if you look over here, what they recommend is that shave, or you can get epilatory treatments as well, or epilatory creams as well. And it happens in patients who are having jobs like where they have to sit constantly. So we advise them, if they can mobilize as well, that is also going to prevent that. So because people with a lot of body hair are more likely to develop pilonidal sinus, they may be advised to remove the hair in the buttocks area. Shaving and depilatory lotions are sometimes recommended as hair removal methods, but you can also get laser treatment as well. But laser treatment is not Medicare covered. Shaving is also not Medicare covered, but if it's a depilatory lotion, then it's prescribed. It's a prescription medication, so it's covered as well. So other treatments, shaving is cheap, but laser is quite expensive. So these are the things we suggest the patient who are having recurrent pilonidal sinuses. It's given by the surgeons, and recurrence also occurs because patient has more than one sinus tract. So we need to keep the sinus tracts clean. And the only way we can do that is to prevent hairs from getting impacted in them. Okay. Next question. A postmenopausal female is taking denosumab. She came with Cooley's fracture. We did more investigations and found that her sacral joint T-score is minus 2.5 and femoral joint T-score is minus 1.5. What do you want to do next to prevent further fractures in this patient? Option A, start alendronate. Option B, calcitonin. Option C, HRT. Option D, teriparatide. So A and C. In postmenopausal females, for the treatment of osteoporosis, we never recommend hormone replacement therapy. If the patient has postmenopausal symptoms and is on hormone replacement therapy, then hormone replacement therapy will prevent further osteoporosis. It has a protective effect, but it is not for the treatment of osteoporosis. You can't treat osteoporosis with that. The treatment of osteoporosis is bisphosphonates. So the patient was on monoclonal antibody treatment, denosumab, was not getting any benefit from it. So we'll start the patient on bisphosphonate because the T-score is indicative of the osteoporosis. Let me just open up. I have no idea why they started the denosumab. It's not the first line agent to start, but if they haven't mentioned what others treatment they have given the patient, start the patient on the basic thing, which is the bisphosphonates. Just give me a second, guys. I'm opening up the where is it? All right. Have a look over here. So recommendation is that, sorry, let me just remove it from here. Plan to prescribe oral bisphosphonates like alendronate, ibendronate, risendronate for at least 5 years. And this is the first line treatment. And then reassess the fracture risk. Longer duration of treatment, we usually don't treat the patient on bisphosphonates for more than 10 years. So recommendation is that if patient is more than 70 years of age, has history of hip or vertebral fracture, has been treated by a steroid of more than 7.5 milligram per day, or has more or one fragility fractures during the first 5 years of the treatment, then start the patient on the bisphosphonates. You can give the patient oral or IV depending upon the patient's preference. If new fractures happen after the starting bisphosphonate treatment, the treatment is discontinued. We reassess the risk by doing a DEXA scan and see if the score is still in the osteoporotic level and start with the second line bisphosphonate agent. But still bisphosphonate is the first and second line drug. If bisphosphonate is discontinued and no fractures occur, then we reassess the patient with DEXA scan after 18 months. And if the patient is having normal score, then we just reassess the patient. You don't need to start it again. Okay. But it's not recommended that you start the patient on the HRT. HRT is not for the treatment of the osteoporosis. It's to prevent osteoporosis, or you can start the patient on HRT because of the postmenopausal symptoms, but not for the treatment of the osteoporosis. So this is denosumab is the second line drug. It's not the first line agent for the treatment of the bisphosphonate. Oh, sorry. What else? Okay, look at this one as well. This is the RACGP guideline. So first line, after you have established that the patient has osteoporosis, we encourage them to start with bisphosphonates. Second line is denosumab. Third one is estrogen replacement therapy. And also in those patients who are having surgically induced menopause, young patient, to prevent osteoporosis, we start them on hormone replacement therapy, but not as a treatment of the osteoporosis. And third line is strontium ranelate if there are contraindications to bisphosphonate use, because you can't give bisphosphonates in patients who are having gastritis, oral ulcers, or gastric ulcers, or patient who are having osteonecrosis of the jaw. Especially denosumab can't be given in that as well. But in those patients, you can try, instead of bisphosphonates, strontium ranelate. Okay. What else? Let me just have a quick look. Falls prevention, vitamin D. Okay. For every patient, we are starting them on bisphosphonate. Always check their vitamin D and calcium levels, because if they are not normal, bisphosphonate is not going to have a good efficacy. So make sure that you have supplemented them with calcium and vitamin D before starting bisphosphonates. Okay. Grade A, B, and C, these are evidence-based. So grade A means supported by evidence. This one is also known as grade A, I think, but usually we use the grade. Same applies for male osteoporosis. Yes, definitely. But if the cause of the male osteoporosis is androgenic cause, then you need to give them hormone replacement therapy. If the patient is having prostate cancer, is on some hormone therapy, then you need to make sure that they also have bisphosphonates on board. Where will we give HRT? So HRT will only be given in a patient who has premature menopause. So premature menopause in a patient who is having like surgically induced menopause, those who have bilateral oophorectomy with self-injectomy, those patients will require HRT. Let me just show you. Just give me a minute. Just trying to find the. Okay, look over here, guys, for those who were asking about when we use the hormone replacement therapy. So first line bisphosphonate, second line denosumab. So hormone replacement therapy is used for women who are recent postmenopausal or for women less than 60 years of age having postmenopausal symptoms prematurely. So this is when we do. And testosterone therapy when patients are having prostate surgeries that requires androgen depleting therapy. You can give testosterone therapy to them if they start developing osteoporosis or osteopenia to prevent further osteoporosis. Okay. Hope this clears your concept a bit. But the first line in all the cases after menopause in male, female with DEXA score of minus 2.5 or less, always start with bisphosphonates. All righty. Yes, so the first line for women with the surgically induced menopause, the first line is HRT, not bisphosphonate. Because HRT, they have to take HRT till the age of the menopause to cause normal functioning of the body as well. The HRT is not just for osteoporosis. Patients with fatigue, tiredness, and weight loss for the last 1 month, serum calcium level high, phosphate parathyroid hormone normal, 24-hour urinary calcium is normal. Diagnosis, so we have done this, and you guys are absolutely correct. This is hypercalcemia of the malignancy because the calcium level is high. The rest of the labs are normal. We have studied that in hypercalcemia of the malignancy, excuse me. The calcium levels will be high, but the thyroid level, parathyroid hormone level will be either normal or low. Okay, next question. 10-year-old Aboriginal boy has discharge coming from, very important to remember this, discharge coming from both ears. Right tympanic membrane is dull and retracted. Also, you have green discharge coming from the nose. What is the most likely sequel of this diagnosis? Cholesteatoma, sinusitis, or hearing loss, or laryngitis? What they're trying to ask is that patient has chronic ear infection, and it's an Aboriginal boy, leading to infection of the nose. What is the sequel of that chronic infection? So always remember, guys, in Aboriginal, acute otitis media is very, very important to diagnose and start the patient from day first of point of contact with antibiotics because it causes hearing loss in them. And you need to follow up these patients with otoscopic examination and audiometry examination. So you have to refer them for that. So have a look at the RCH guidelines. They are the high-risk group, so they need to be started on antibiotics on the first day. The other thing is that they need to be followed up with the hearing test. So if you look over here, red flags, so Aboriginal and Torres Strait Islander children are at high risk of getting hearing loss. The special thing about them is that firstly, they don't respond well to just observation because their sequelae or their progression of the disease in this high-risk group develops more. The second thing is that if we don't treat them, then the sequel of getting hearing loss or getting chronic otitis media associated with hearing loss is much more higher. And the third thing is that they don't have very good healthcare system, or they don't have, well, how to say this? There are different cultures among them. So we have to respect that. They don't seek the help regarding their health. So it's a bit important to keep them on your radar. Yes, I agree with Dr. Imran. If they have low health seeking behavior, not compliance to medication is not a problem. It's just that a contact with a healthcare person there's barriers to that. So whenever we do that, we advise the parents to seek medical review, and we check the patient with the otoscopy and pure tone audiometry, because they can have hearing loss. So very, very important, and can develop language problems because of that. Clear, guys? Okay. Any question, guys? Okay. A 10-week-old baby has a history of difficulty in breastfeeding with poor weight gain, presented with cough, vomiting after feeds, shortness of breath. On examination, there are intercostal recessions. Pulse rate is 160 high, respiratory rate is 65 high. Bilateral crepitations and wheezing. What is the provisional diagnosis? Excellent. So we know any baby, any neonate, or any newborn less than a month old is presenting with upper GI symptoms associated with respiratory symptoms. Consider tracheoesophageal fistula. So patient will vomit after every feed, have poor weight gain because of that, can aspirate it as well, leading to cough and crepitation and wheezing in the chest on examination. So unwell patients, they will be. Type C is very common. I agree with Dr. Prakash. Type C is very common, where the distal end of the esophagus is blind, distal one end of the esophagus is blind and one end is connected to the trachea. I'll show you guys. Now, in pneumonia, patient will have vomiting, but the vomiting is not associated with the respiratory symptoms. Respiratory symptoms are associated with vomiting. Bronchiolitis, you will have respiratory symptoms, poor breathing, but there will not be crepitation. There will be wheeze on the chest. So if you look over here, the RCH guideline, you need to do surgery to repair this, but identification of these patients are also impossible. Is very important early. So if you look over here, there are different types of it. So distal esophageal atrasia with the distal part connected to the trachea. This is the most common type. It's also known as type C. Pure atrasia is that none part is connected with the trachea, and patient does not usually survive because they can't feed. And less common is that the proximal end is connected to the trachea, while the distal end is a blind pouch. And double as well, but this is very, very rare. Surgery is required for this. That is the only treatment. So you just separate the esophagus, which is connected to the trachea, close that part of the trachea, and combine both ends of the esophagus. And these patients needs to be followed up by a pediatrician throughout life, because they are high risk of having GERD problems. So they need to be on a PPI therapy as well. Okay. Any question, guys? Next one, appendectomy is done in a patient, and that patient was discharged. Comes back in a week with fever, high-grade fever, chills. Cannula site is red, surgery site is a bit inflamed and tender, but DRE is tender. So what is the diagnosis? Cannula site infection, surgical site infection, pelvic abscess, or Clostridium difficile? How to feed with TOF? You can't feed with TOF. These patients have to be admitted, started on parenteral therapy, unless they have a corrective surgery. Excellent, guys. So if a patient has a surgery done, comes back, especially appendectomy, has high-grade fever and chills, so they have systemic infection, right? Cannula site is just red. Surgical site is red and inflamed. No problem. Patient can have a surgical site infection. But our tender DRE indicates that there's a formation of abscess intra-abdominally. It is also positive in pelvic inflammatory disease, DRE. So in this patient, because he had or she had the appendectomy, we will suspect it had led to the formation of the pelvic abscess. The DRE tender is very, very important for a sign for you guys to pick up pelvic abscess. Cannula site infection, the cannula site should not be just red, it would be swollen, it would be warm, hard, hot, tender to touch. All the signs of cellulitis should be there. Surgical site infection, we would call it surgical site infection, but if they have given you a specific diagnosis based on the symptoms like DRE is tender, then pick pelvic abscess. It is a surgical site infection, but it has evolved into a pelvic abscess. 1 week time is not long to develop abscess. Usually post-operative abscesses are developed between 3 to 5 days. So 1 week is normal. Patients who are having appendiceal abscess, they most of the time the mesentery forms a mass around it. So it's contained for the first few days. All right. Next question. I don't think so. There is anything to explain in that question. It's quite self-explanatory. A boy came worried about his body, said shoulders are too narrow, joined the gym also, still does not feel good about himself. So we all know this is a body dysmorphic disorder. I think one of you picked B. Doctor, it can be associated with the eating disorder if patient has extreme body dysmorphic disorder. But first and foremost, the cause is that he doesn't feel good about his body, but they haven't mentioned his eating pattern or mentioned that the BMI is low or mention any physical signs of the restrictive eating disorder. Complex personality disorder is not a term. There is no term. It's just a misnomer. There's no term called complex personality disorder. This is a body dysmorphic disorder because if you see the first line, they have said boy came worried about his body. Said shoulders are too narrow. So he's worried about the shoulder part and joined the gym as well. Still doesn't feel good. So joining gym is not related to eating. Joining gym is related to bulking up because he thinks that the shoulders are too narrow. So I believe that this patient wants to have broad shoulders, and that could he joined the gym to increase the muscle mass over here. So this is typical body dysmorphic disorder. If you guys look at this, looking in the mirror is also one of the pathognomic symptoms, but just being concerned about particular part of the body all the time, think about body dysmorphic disorder. If you look over here, it can be muscle dysmorphic. So our patient has that. It can be a skin picking disorder. It can be a hair pulling disorder, nail biting disorder. So preoccupation about the defects of the body, excessive grooming, avoidance of the social situation, comparing oneself to the others. These are all symptoms of the body dysmorphic disorder. And what we do for treatment is because there is an underlying anxiety element to this disorder, we start the patient on cognitive behavior therapy, and we support cognitive behavior therapy with SSRIs. All right, that's it for today. Thank you so much for joining the class. I hope I have done justice with you guys. So this is how we take the MCQ classes every week. So I would recommend you guys, if you're looking to pass your exam and you want help in that regard, first aid AMC course is definitely the way to go. All right. Thank you so much, guys. I hope you had a wonderful evening. Have a nice night. Thank you. You please tell me about the answer for Aboriginal child. So any Aboriginal child who is coming with acute otitis media, we start the patient immediately on antibiotics, amoxicillin, clavulanate. And if the patient develops chronic otitis media, the sequel or the complication associated with that is hearing loss. Yes, these kinds of questions come in the exam. Some are more difficult than these, some are more easier than this. It's a mixture of things that you will get in your exam. Summarize the osteoporosis treatment. First line therapy, bisphosphonate. Second line, denosumab. HRT for premenopausal patients, strontium granulate. If the patient is having in contraindication to bisphosphonates, teriparatide or selective estrogen receptor modulators is the fourth and third line one. Yes, you will get every topic-wise theory. Topic-wise MCQs will be available on the portal. And the sample question classes will be a mixture of everything. So we discuss the questions that are coming every month in the exam year. So that's how we do it. Thank you so much, guys. Any other questions? All righty. Handbook is a must thing to do, Dr. Prakash. It's very important that you follow handbook. It's a crux of the exam. How many classes next week? So every week we take 3 to 4 classes. Yes, the links that I have used as a resource will be provided in the video. So if you can copy it from there, it will be everything. Handbook will also be given with the AMC MCQ handbook is important, guys. You can download it from anywhere. It's available. It's also available on MCQ sites. How to utilize the question solver class. Just look at the way I'm trying to pick the right answer and get a good grip of the patient. It will be uploaded as soon as possible. You should do handbooks side by side. Always do handbooks side by side. Not necessarily, it depends upon you. No, we don't cover the AMC handbook questions, but we do discuss whether any of the sample questions is from the handbook. All right, guys, have a good evening. Thank you so much. Yes, handbook means AMC handbook. Thank you. I hope you have a lovely evening, everyone. Thank you so much.